I love introductions. So they're always like, who is this guy? It sounds better than who I expected. So I did my doctorate of nurse practice at Sanford University in Birmingham, Alabama. And this is the presentation for my DNP research. But it's not just my DNP research, it's my lifelong pursuit. And so I get to continue it as well. So the title of the program is The Evaluation of a Community-Based Program on the Health Indicators in a Food Insecure Population. So that's what we're looking at. Food insecurity is crazy that food insecurity even exists in the United States. But by food insecurity, we mean that is a population that does not have a reliable access or sufficient quantity of nutritious or affordable food. So they either lack quantity or quantity of their meals each day. And people who are food insecure are at risk for hypertension, diabetes, and obesity. 1 in 6 Americans are food insecure. 1 in 4 children are food insecure, which is a crazy stat because in the United States, we raise enough food to feed the entire world, but we don't, which is another topic for another time. Hispanic and African American populations are at greater risk for food insecurity, and they are at higher risk than non-Hispanic. Community centers and churches that serve the underserved have an advantage in building sustainable programs that have lasting impact. I first got involved by being asked to be part of the South Plains Food Bank. They began a health advisory committee where we sat down and began to address how can we help people who are food insecure. Because people who are food insecure have to rely on food banks in order to get the food that they need to feed their family. The problem is when you go to the food banks to get food to feed your family, that food isn't very healthy. Because when you think about it, when we have a food drive, what do we collect? We collect the cheapest food available. A lot of top ramen, and you don't see in the donation bins low sodium. You don't see any healthy foods. It's always the cheapest foods. And so the food banks, in fact, Feeding America, it's a coalition of all the food banks in the United States. They're looking at how can we change that? How can we help people who rely on food banks? Because are we really helping people by feeding them, but then putting them at risk for obesity, hypertension, and diabetes? So they're at a little bit of a quandary there. So they're trying to change that. So they began a health advisory committee, and I got to be a part of that. And from that, I found out that the Dream Center is a distribution point for the South Plains Food Bank. And so then I connected with the Dream Center, and we began to work. We established what's called the Action Family Plan, or Action Family Program. The Action Family Program serves about 100 people every week. It's located in a very underserved part of Lubbock. It is in the just south of downtown, kind of towards the east side of Lubbock. What the research says is that faith-based initiatives can have an effect in increasing the health outcomes of their participants. And the reasons are kind of fairly obvious. They're located in places where they're needed. They have the facilities that they can use, and they can partner with multiple other organizations. And so it's up right into the community where it's needed. We have an amazing food bank here in Lubbock, brand new facility. It's beautiful, it's wonderful, but it's not located in the neighborhood of the people that need it. And in fact, you can't ride the bus to get there. You can get within a couple of blocks, then you have to walk. So if you're walking, if you go to the food bank, you get off the bus, walk 2 blocks, get a box, and then carry it back to the bus station, it makes it a little difficult. So although we have a great food bank and they try to do as much as they can, they're at a disadvantage and how can you be located in the situation? So that's why you got to look at where can we go. And the Dream Center is located in a high need area. By using the church facility, by using that community, it builds camaraderie, it builds accountability. People see each other, they talk, and it builds a great fellowship because the people see and know each other. And they follow up. Hey, I didn't see you last week, and how you doing? So that community there really works. The Action Family program on Saturday mornings, when they come to receive their food basket, in addition to getting their food, what the Action Family program decided to do was to have healthier food choices in the basket that they're going to receive. So they decided to buy or get less food from the food bank and then take money. They have a grant from Covenant where they go out and they buy healthier food options. So they get a good protein and fresh vegetables that are included. On Saturday morning, in one room, all these things happen at the same time. There's a free breakfast being served, so people can come in, they can get a free breakfast. We have our health screening, health prevention, health education, all along one wall. That's taking place. And then right in the middle, they're having a food demonstration based on the food that they're going to receive in their basket today, which is a very effective way to do that. So if you give people healthier food, let's say you give them a spaghetti squash. If you give me a spaghetti squash, my first response is, I don't like it. Because I don't know what it is. I don't know how to fix it. I don't know how to cook it. And so you give people healthy food, but they don't know what it is or don't know how to prepare it, they're going to throw it away. So instead, they actually have a food demonstration that shows, here's what a spaghetti squash is, here's how you can fix it. And they made Thai pate out of the spaghetti squash, and it was delicious. So people got to see it, taste it, and so that they get a recipe and the food delivered with them. At the same time, we have our health screenings going on, where we take their weight, their blood pressure, check their blood glucose, and have an opportunity to connect and talk with the participants individually. Each nurse gets to sit there and have a time to speak. It's kind of a madhouse, but it's really cool. So, I forgot one thing. The other thing that they have is we also do health education. Not only do we do it while we're sitting there at the health screenings, but once a month we have a health education class. So I taught a class on how to take your meds and had all the people come and bring all their meds with them. And I actually had 25 nurses come with me, and we had 25 people show up. So nurses sat one-to-one, and we went through all of their meds and discovered some people were taking more blood pressure medicine than they needed because they saw 3 different doctors, they got 3 different prescriptions. Some people didn't understand. It said 3 times a day, but they couldn't remember to take it 3 times a day, so they took all 3 of them at breakfast. So those kind of things we got to have conversations with and teach. Then we've had classes on diabetes, high blood pressure, fall prevention in the home. Did a class on children's immunizations, and this month the nurse practitioners from here are going to teach a class on adult immunizations. So once a month we try to have a health class that's related to the people that are there. And then we also get to have that one-on-one time where we get to have those conversations. Notice your blood pressure's high, how you doing about that? Yeah, well, when I have a headache, I take my medicine. Well, that's an opportunity then to have a discussion on that's not when you take your medicine. That blood pressure medicine requires you to be on it for a while in order for it to work. It's not like a Tylenol. You can't take it when you feel bad. Then the last thing that they have that's very effective is the walking club. The walking club is an opportunity for participants to come to the Dream Center and walk for 30-minute segments, up to 1 hour. So they can walk 1 hour a day, 4 days a week. Now, in order to get people to do all these things, they get Action Family bucks. So if you could do a health screening, you get an Action Family buck. If you go to a health education class, you get an Action Family buck. If you do the walking, you get an Action Family buck for every 30 minutes that you walk. You save those Action Family bucks, then you can turn them in for prizes. The most requested gift is the $25 Walmart gift card. So you collect 35 Action Bucks, you can turn it in for a $25 gift card, then you can go buy some gas. So that's the incentive program and how it works. So here's my research question. In a food insecure adult population, did the health interventions, the health screening, the education, the walking club, have an effect on the health indicators of weight, blood pressure, heart rate, and blood glucose over a period of 1 year? So that was the official research question, and for the theory behind it, I used PENDER'S health promotion model. And I really like PENDER'S health promotion model because PENDER'S is a holistic approach to get people to understand the choices that they have. Because people make choices based on the options they think they have available. In my class, I always tell the students, why do women date loser men? The last guy they dated was a loser man. This guy they're dating is a loser man. Why do they keep dating loser men? Now, maybe they like loser men. That might be one reason. But another reason is they don't think they have a better choice. When they look at their options, they think they only deserve loser men. Well, the same thing happens in health. Why do people make bad health decisions? Because they don't think they can choose anything better. So in our health promotion model, what we're trying to do is get people to see that through the Action Family Plan, that there are you have other options. You don't have to do this. Just because your grandmother's diabetic, just because your mom's diabetic, just because you're diabetic, doesn't mean you can't do something about it. And so we try to change their perception on their health. Here's how we did it. I did a retrospective chart review in the research. So I looked at the charts for a period of 1 year. I got IRB exemption from both Lubbock Christian University and Sanford University because I was looking at the charts that the Action Family Program already has, even though I'm the one that wrote them. But I looked at them and got to collect the data from those things. And so I looked at the health screenings, the health education, and the walking club. We took all that in, and then I put it all out on this big long spreadsheet in SPSS, and I did a paired t-test to compare the beginning and the ending things. We also looked at the demographics. I used 45 people out of the 100 that come every week. There were 45. I tried to select people that looked like they came the most, so I wouldn't have big gaps in the research. Because some people would come once and then wouldn't come back again for 6 months, and some people would come for 3 weeks in a row and then wouldn't come for a couple of months in a row. So I tried to find people that came the most often. So I ended up with 45 people. It broke down the demographics broke down just like the community: 67% Hispanic, 22% white, and 11% black. 67% were female, and 33% were male. The age range was from 24 to 76, with the mean average age of 60. So that's the records that we looked at, and then we did the test, and here's the results. By looking at their weight over 1 month, over a year, 12-month period, those 45 people lost 286 pounds. And you have to remember their average age is 60. So for 60-year-old people to lose weight is a big deal. Their blood pressure went down. Both their systolic and diastolic blood pressures went down. We saw from doing that paired t-test that a statistically significant difference between the mean pre-intervention and post-intervention scores support improvement in overall weight loss and systolic and diastolic blood pressure. Now, just for the statistic nerds, I got one more slide. This shows our paired samples t-test, and then we've added our Cohen-D test. Cohen's-D is used to measure the effect of the results, to make sure that that has the effect that we wanted it to have. It wasn't a fluke. And so in the Cohen's-D, let's see, I wrote here, Cohen's-D was calculated as a quantitative measure to determine the strength of the results. The intervention had a medium to large effect. So that tells me that the Action Family Program worked, that we actually are able to make a difference in that community, those people that we see over and over again. Now, not everything worked, and that's where we realized that we need more research. In order to do things, when I looked at the research, any program that was initiated that wasn't longer than 6 months doesn't work. And I saw from my own research that when you try to work in a poor population, if you go in and you do something for less than 6 months, it's not going to work. That's because a lot of people do stuff for the poor population. And they blow in and they blow out and nothing changed. It takes time for them to develop trust and to accept you. For the first 6 months that I went, nobody talked to me. Nobody. And I was asked by the Dream Center staff, are you coming back? Every time I showed up. Because they didn't believe I was coming back. Because people come in, they do their good thing, and then they leave. And so if we're going to build anything in working with a poverty community, you have to be prepared to stay. It takes time. I've been there now 3 years. Now when I walk up to the door, I can't get in because everyone wants to talk to me. Because now they know me and they trust me. Now they still ask me every once in a while, am I coming back? And the answer is still yes, because I'm seeing that this actually works. Let's keep doing it. Now the blood sugar management didn't work. Now on the statistics, when I looked at it, I had the starting numbers were here and the ending numbers were down here. I thought, oh, it worked. But then I looked at the participants. The people with the high blood sugar dropped out. They stopped getting their blood sugar tested. So if I looked at a pre and post total, the blood sugar went down. But if I looked at the reality, it didn't, because the people with the high blood sugars dropped out of the study, which caused me to think, well, how come is that? Why do people drop out? And I had the opportunity to ask one guy, and it's a great story, because this guy, when he first started to come, he was just an angry, grumpy old man. And you ask him, his blood sugar would be 300, 280, 250, back up to 300. And so I asked him one of the very first times, do you check your blood sugar at home? And he says, oh, I got one of them machines. I don't know how to use it. I said, well, if you bring it, I'll help you. I'll show you how to use it, and we'll work on it. And he goes, rah, 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 and he walks off. And he would come back the next time, 280. So how you feeling? Do you realize that what this is doing to your body? And he'd go, rah, 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 and he'd walk off. And then he stopped coming. He stopped getting his blood sugar checked. He still came, and he'd get his blood pressure checked, but he wouldn't get his blood sugar checked. So I asked him, why'd you stop doing that? He said, I got tired of hearing the lecture. Which then brought up the question, what are we teaching and how are we teaching? Because how we're teaching is not effective. If people don't want to hear it, then we're not doing a good job, which brings my what I want to do next. I want to figure out how can we teach at a level that is effective. So I have a friend that's a professor at Texas Tech University, he's a neuroscientist, and he does the effect of advertising on the brain. And he said to me, negative advertising doesn't work. That's why those stop smoking commercials that you see that are very gross, they don't work. Because there's a thing in your brain that when you see negative things that you don't want to hear, you turn it off and you don't hear it. That's why respiratory therapists, nurses, and doctors still smoke. They know, but they still do it. So knowledge isn't the problem. So when we teach in Bloom's taxonomy of knowledge, we teach on the cognitive level, it's what people know. Then there's the affect level, it's how people feel and it's where their values are, and the psychomotor level. We look at our teaching in nursing, most of our teaching falls in the cognitive and the psychomotor level. You have a person who's a diabetic, we tell them what it is. You have diabetes, and it's sugar in your blood, and it's doing this to you, and we tell them all that. And here's what you need to do. There's medicine you take, here's a syringe, you can practice with the orange. So we teach them cognitive and we teach them psychomotor, but we don't teach at the affect level. Because the effect level is harder to teach. And it's almost impossible to measure. So how do we help that? How do we change that? So that's going to be my next direction that I want to do, because I see the changes in that. What changed in this guy? Because now I walk up and he's standing at the front door with his finger up in the air saying, today, 170. He's predicting his blood sugar. It was 180. And he was so discouraged. And I said, dude, it was 250, 280, 300. Now it's 170. You're doing really good. What changed? He goes, well, I kept thinking about how much you tried to encourage me to do all this. So I enrolled in a diabetic education class at the community health center. And I'm really trying to be different. And not only is his blood sugar lowering, but his whole attitude has changed. You wouldn't recognize him from the first time we saw him 3 years ago, because it's beginning to get it to his affect level. His values are changing. A woman was asked, why did how did you lose weight? You're 60 years old. How did you lose weight? She says, I wanted to see my grandkids graduate from high school. See, that's at the affect level. That's not at the knowledge. It's not at the psychomotor. It's at the affect level. And so that's what I want to do next. And I want to continue our partnership and hopefully build to newer and greater things. Have any questions? For the community health class, they are the volunteers that come. I force them to come for their practicum hours. They get the opportunity to volunteer and go there twice. So they're the nurses. So I actually have RNs doing the intervention. It's really cool, and I really appreciate their work. And it's good to see some of them in the room today. So, any questions?
Is this only going to be at the dream center, or are you trying to make it more like a local thing so it can be on the locations? Because it's obvious that people in that area or the dream center are the ones benefiting from it. I believe that it's such an amazing implementation for the community, but also for the greater good. So are they trying to think of some?
We're still talking with the South Plains Food Bank as to how else can things be done. One of the difficulties is location. South Plains Food Bank would love to do things like this, but nobody lives within walking distance of the food bank. So they're trying to figure out how then can we get this into other communities. So I've started to partner with the MICA group that's based on MICA 6. It's a group of chaplains, and they're trying to get interventions into communities more. So I just now started partnering with them, and so we'll see where we are able to take it from there as we try to get into other communities. Any questions? Oh, that was the fastest I've ever done that. And I have a whole bunch of references there. I'm sure you wanted to read all of them, but I had to put them in there just for Dr. Long's sake. All right, thank you. I guess you're up for a rebuttal. Yeah.
Thank you, Dr. Wilkinson. Fascinating to see somebody doing research in some type of intervention with this type of clientele. There's all types of things out there that I've seen dealing with homeless and underserved, and what we see over and over again is just what Dr. Wilkinson was saying. Small groups coming in, doing a little something, and then quitting. Another group comes in and then quits. The ones who make the commitment and stay with a long time are getting results. And so maybe the approach is just like what Dr. Wilkinson is talking about based on his research. Look, results as a result of a commitment. Now the challenge is, who will make the commitment? I still dream about nurses stepping in and functioning in these areas. Why couldn't master's level nursing students go to the open door and do the same thing? Or to Lubbock Impact or do the same thing? Or the community health care center and work alongside of them and continue these type of things. That's based on what he said in his research, that's what's working. And so that's just a matter of volunteers willing to do that. And that's the challenge, is finding those volunteers that will continue. But I love to see what was done, because the heart is, want to make a difference for these people. Can we make a difference? So many times in the hospital setting, we see people come in and we want to do something, but our time within the hospital setting is so limited. And we're so busy with other things, it's hard to do. So why not take it to the community and work with it? I really appreciate the research you've done, but I really appreciate the work that you're doing. It's come behind the research and ongoing as a result of the research. Thank you, Dr. Wilson. I think this is fantastic.
I have a question for you, Dr. Wilkinson. I know that you presented at Dublin and in Dublin, Ireland, and are planning on presenting elsewhere. I think one of the things we know is that to reach the widest swath of people with this information, it's got to get into the literature. And that's, and it might not even happen immediately, but over time, others that are interested in it, if it's published somewhere, then the likelihood is that you're going to reach people not only, in the United States, but others. So where are you thinking about trying to publish this, and what's your time frame?
I have two places that I'm looking at trying to publish. One is the Journal of the Christian Nurse Fellowship. They have a Journal of Christian Nursing. I would like to publish there. And then there's a new magazine called Church Health. I would like to also publish there. And I'm also trying to get into the American Community Health Nurse Educator Society. I'm a member there, so I'm looking for opportunities that I could advance it from there. Yeah.
Like that. There's different, one thing to think about is who's going to read it. And you'd love to have church, faith-based groups step in, but nurses often have that vocational calling, so getting it someplace where nurses are the target audience might be useful as well.
Right.
Yeah. Did you find, one other question, did you find is cost a factor for those with chronic diseases not being able to get the supplies that they need?
Very rarely. Because, especially here in Lubbock, we have so many resources that if they don't have the testing strips, they don't have the meter, there's somebody out there who'll get it for them. So we send people to the Larry Combat Center for diabetic education. That's where the gentleman went that I was working with. And they do a great job of helping people. Even the South Plains Food Bank had a diabetic education class, and they were able to help people get the supplies and things that they need. So I haven't found anybody in Lubbock yet that we can't connect them with somebody who can get them the supplies.
Are international organizations trying to move the food donations to a healthier status? Have you read about that?
It's a nationwide thing that they're doing now. I mean, it's hard because when you collect food, you get what you get. But there is the Feeding America is the big umbrella, and they're trying to say, what can we do to make our food healthier in order to prolong and protect health, not just feed bellies. So it is a national program that they're working at.
Because the best thing is fresh fruits and vegetables, and those are perishable. So when you have massive food banks collecting food that's dispensed over maybe months, it's a challenge.
Right. Well, then that's why some of the food banks, like here, we have an orchard. Here at Lubbock, we have a large orchard that they do that. I was just in San Antonio last week. San Antonio has one of the largest food banks in the nation, and they have like a 40-acre farm. And so in season, they have fresh fruits and vegetables that they use. So I would like to actually go down there and visit with them and see what they're doing a little bit more. I found out about it the last day we were in San Antonio. So.
With all that you've done up to this point, it's obvious you're the heart and soul of what you've got accomplished. Have you looked at what will happen to the program if you're not there to do that?
I have a plan. At the conference I was at in San Antonio was a community health conference that we were at just last week. One of the nurses presented a developing community health nurses. So at the Dream Center, we have an RN who is there and runs a nurse clinic. Now, it's not a nurse practitioner, just an RN, and runs a nurse clinic. And under her or him, there are community health workers. So you go into that community, like we'd go into the Dream Center, I get a nurse, you get a grant to pay them, you get a nurse there who's going to be looking at the people and what's going on, and then have community health workers that come from the community that you train to go out and do all your follow-up and work. So that's the great dream that I have next that I just heard about last week, and that I want to go. See, that would make it sustainable. And the Dream Center, interestingly enough, the Dream Center is located in almost every state. They're across the United States. It's based on the Dream Center in LA. If you go and look on the web and look at the LA Dream Center, it's amazing. They have a hospital. They have all kinds of crazy things there. When I was in the doctorate program, I was on a conference call with somebody, and they were doing some of their practicum hours at a Dream Center in Virginia somewhere. There's one in Philadelphia. There's one in Birmingham. So they're across the United States. So if we could build it here really well, then we can then also help the Dream Center itself become the ones who can promote it, because they do the same kind of work in every place. So there's opportunities to expand it. But my goal is to hire a nurse to be the nurse for that community and get some community health workers to work under her. So we're ready to go eat? They're a ministry of the Church on the Rock, so that's their first line. And then they receive grants and donations from everywhere. And it's pretty cool place. Every building they have is paid for. So you go out there and you see everything they have, it's all paid for. The Talking In Foundation built their multi-purpose building. They give them $1 million or something like that, and they did that. They're now building a housing for women coming out of prison. That's a need. There's different programs for men coming out of prison, but there's very few programs for women coming out of prison. So they're building a place there for women can write a new chapter in their life. So they're building that, and that building's already paid for, and they haven't broke ground yet. They were raising money for that. Guy walks in off the street, says, "I've heard about this, and I'm going to give you this money," and it was exactly how much more they needed to finish paying for it. So they're just blessed by God. It's working.
I have a comment. This is wonderful, by the way. I'm a diabetes educator, inpatient, and so I came across an article through my news feed, I guess probably 2 weeks ago, from the British Medical Journal. And so it really caught my eye because it's talking about food, and it's talking about, and what they did is they took, I forgot now how many people, but the majority of these people were African American. And they were older individuals, maybe around 60, I can't remember. I've got the article in my office, but what they did is they switched the meal plan from the traditional, what everyone is recommended to do by ADA, and instead of more carbs, they flipped it and did a 40% protein, 40% carb, 40% fat, 30% carb, 40, 30, 30. Is that right?
That's 100.
Versus the regular 55% carb, 30% protein, 30% fat. And so this was done over, I'm thinking 3 years. And so these individuals, they tracked everything. They had, they tracked their data, what their blood sugars were, what they ate. And over the course of that 3 years, every single person reversed, these people all had pre-diabetes. They all 100% reversed their pre-diabetes, and blood sugars were now all normal. So was blood pressure, lipids. So I think what makes you really think what we're doing currently with our standards through ADA versus what could happen if we changed that percentage and we all increased protein more so than carbs. We all know that. I mean, we're not dumb, we read it all the time. But that shows you that it can be done, and these were individuals that we know ethically don't have a history of eating healthy, but they were able to change their habits because it was, yes, you can have more protein and less carbs. And anyway, that was just very interesting to me to see when you change the percentage of what you're eating and you're eating more of protein. And the thing is that we're all fearful of fat, and we shouldn't be.
Right.
We shouldn't be at all. It's the carbohydrates that are the issue.
Right.
So
That is one of the things they try to do is make sure there's a good protein in the meal plan. That's one of the major things they look for.
And I'm curious about the gentleman. Was he on what medicines was he taking, the one you're talking about, and did he follow up with the PCP? Did he, could he afford his medicines?
Right. Well, he's now part of the Larry Combest Centers. He's in their diabetic program, so he's being seen and followed up on the medical side through them. And he wasn't on insulin; he was on oral medications.
And I just want to share too something that would be beneficial is you can now get Lantus and Apidra, both long-acting and rapid-acting insulins for $0 copay for 12 months right now. So with just registering online through Sanofi. So that's fantastic.
It is.
For anyone one.
Yeah, because we were, in the conference I was in last week, they talked about how expensive it was to be a diabetic. And that's one of the reasons we like to label everybody non-compliant, but we don't understand if it costs you $1,000 a month, it's not because you're non-compliant, you're broke. So it was a interesting presentation they did in San Antonio on that. Similar thing. Yes, ma'am.
Is there a plan to expand the program to target the pediatric population? Currently, the Junior League of Lubbock has a signature project called Food to Kids, which aims to serve 1,700 to 3,700 in the span of a year, kids who are food insecure. But having worked those shifts, the bags are loaded with sugar and items that have a higher shelf life. But if there's some kind of program where we can distribute fresh fruit that will make it through the weekend for them.
Right. That'd be great.
Yeah.
I'm all for it. So, in fact, our population was average age 60. At the clinic, we don't see any children for the health screenings, although there are lots of kids in the community. I would like to see what can we do to reach some of those younger population. One, we don't have space. We're maxed out right now where we're at. But I would like, you could email me and we could talk about how could we get because we're always looking for partners. I don't believe in reinventing the wheel. If somebody else has got something going on, let's partner and do it together. So I would be open to talk about that. Okay. All right. Thank you so much.